Hi everyone, my name is Ashley and I'll be presenting on implicit bias and healthcare disparities with nursing implications. Imagine you live in an under-resourced community struggling with poverty, racialized violence, and limited educational opportunities, social determinants of health that lead to poor health outcomes. When you seek healthcare, you are met with predominantly white healthcare providers who are trained in a biased learning environment and practice racialized medicine. Their implicit biases towards marginalized patients influence the way they communicate with you, manage your pain, and recommend treatment. You sense their bias, distrust your provider and the system, and decide not to follow through on their treatment plan. Your provider labels you as difficult and non-compliant and observes the generally poor health conditions of people from your community, confirming their biases and perpetuating a vicious cycle. It may sound absolutely contrary to what we say we believe, but do we subconsciously judge a person's worthiness to health and care that somehow one person is less deserving based on appearance? Implicit bias refers to the subconscious attitudes we hold towards people based on characteristics such as race, gender, age, socioeconomic status, or physical or mental health condition. As nurses and healthcare providers who make clinical judgments and decisions that impact patient outcomes, identifying and overcoming our implicit bias matters. It matters because as nurses, our ability to empathize and advocate for patients, as well as establish trusting therapeutic relationships, is seriously undermined by our negative implicit biases. It matters because implicit bias can lead to suboptimal patient care, reinforce systematic racism, and ultimately contribute to health disparities. Although there has been more focus in literature on the impact of physician bias contributing to diagnostic or treatment errors, nurses too make clinical judgments that impact patient care and outcomes. For example, studies cited by Danielson 2017 show that nurses' negative attitudes towards persons with psychiatric illness, including assumptions of aggression, noncompliance, and inability to interact meaningfully with others, can lead to avoidance, neglect, over-administration of sedatives and antipsychotics, underdiagnosis, and overall poorer patient outcomes. Factors that contribute to nurses' implicit bias are multifaceted, including simple lack of skill, knowledge, or support, feeling afraid or unprepared to care for this specialized population. Systematic upstream Systemic upstream factors, such as policy that limits insurance coverage and community access to mental health care, results in large number of psychiatric presentations to the emergency department that could have been addressed with proper preventative or follow-up care. Speaking of the ED, numerous studies have shown that implicit bias can result in patients being triaged with lower scores or given different pain medication or doses, as documented in a scoping review by Thirsk et al. 2019. One study by Boyle et al. In 2019 asked healthcare major students, including nursing students, to respond to various pediatric pain management simulations. They were asked to rate the child's pain, their sympathy level, and motivation to help the child, and to report what they believed was the cause of the pain. For obese or overweight children, participants were more likely to attribute pain to behavioral or psychological issues. Correspondingly, participants had less sympathy and less motivation to help higher weight children in comparison to children of healthy weight. In another qualitative study by Mill et al. In 2013 that examined the stigmatization of patients with HIV and AIDS, nurses reported observing that patients who were HIV positive were placed in rooms further away from the nursing station, were not turned in bed, and had delays in being provided bedpans. From impacting the likelihood of escalating patient concerns to the provider, offering interpreter services, ancillary treatments such as the HPV vaccine, or screening for intimate partner violence. The list of studies documenting implicit bias influencing nursing decisions goes on and on. It's especially troubling that our implicit biases compromise provider empathy and patient provider relationships, because patients who perceive that they would have received better care if they were of a different race are more likely to not adhere to provider advice or to delay care. So, what can be done? Several techniques to reduce personal bias have been suggested, including stereotype replacement, that is, replacing stereotypical responses with non stereotypical ones, individualization, learning individual attributes of persons rather than identifying group attributes, increasing opportunities for contact, and perspective taking, taking the perspective of persons present. Unfortunately, studies on the efficacy of these techniques are limited, showing temporary or non-reproducible results. Clearly, there's more we can do. Consider the scenario I described at the beginning. Imagine if nurse leaders collaborated across disciplines to create policies that promote diversity and anti-racism in our learning and working environments. Faculty created and supported a culture that invites and retains diverse students. On a side note, implicit bias not only affects patients but also minority students and providers who face daily microaggression and bias, leading to feelings of isolation and substantial stress, which can affect performance. Minority health professionals are underrepresented in the workforce and even more so amongst faculty. Promoting diversity in these settings will increase the likelihood that the provider shares lived experiences with the patient and is recognized as an important mechanism in reducing health disparities. In our scenario, the patient notes an absence of provider bias, trusts the provider, adheres to the treatment plan, benefits from favorable social determinants of health in the community, and returns with improved health outcomes, confirming the provider's more favorable bias in a positive cycle. It's encouraging that discussions around health disparities have begun to shift the responsibility from the patient to the provider and the system, and from race to racism. Let's continue to hold ourselves accountable, not only identifying and combating our own personal biases, but also advocating for the broader systemic changes that must be made in order to move towards true health equity. Thank you for listening.